We will just hear sir's presentation on clinical pictorial representations of infectious diseases. Over to you, sir.
So am I audible?
Yes, sir.
Yeah. Yeah. So thank you so much for this invitation. And it's really unfortunate that I'm not able to be there. I would have loved to be in Pondicherry to be among all of you. But anyway, so I'll start my presentation. I'll try and share my screen. I'll see if everything is okay, and then I'll start. So is my screen visible?
Yes, sir.
Yeah. Okay. So I think I have 20 minutes. So I'll jump right into the talk. So I was supposed to actually talk on, I guess, pictures and infections. So what I thought I'll do is actually give you a glimpse of certain conditions that I have seen. Some of these pictures are what I've taken. Some of them are what my friends have shared with me. And some of them are from publications. But all the pictures that I'm going to show you are all the conditions that we have seen. And some of them have been dilemmas till till you sort of figure out what it is. But once you've seen one, then it's very easy to actually diagnose the next one. So towards that, like I said, some of these are common, some of them are not uncommon. But either way, they are all, these pictures are often pathognomonic of what they represent. So that is why I put up these pictures. Now, whenever we think about an infectious disease, even though we are looking at clinical pictures, we should always recognize that what we are looking at represents a microorganism, which is what is actually causing the disease. So if we keep that in mind, then we would actually try and get what that microorganism is, which causing the disease. It could be a virus, bacterium, it could be fungus, it could be a parasite, but there is a microorganism involved there. So your treatment is actually targeting that microorganism. So I'll start with some few case scenarios. Some of them are common case scenarios. I mean, this is a 2-month-old boy who came with fever for 2 days and a rash for a day, also had loose stools for 1 day. Now, some of you who've experienced pediatricians, I'm sure you must have seen children like this. So this is the child. I mean, you can see that there is a rash which is sort of predominant on the lower half of the body. You don't see any bullae here, but I can tell you that this started off as a bullous rash, and you can see areas where the skin has broken down, and there is areas of hyperpigmentation. This is just another view of the same child. I mean, you can see some bullae here on the right leg. I mean, so these bullae break down, actually leaving these raw areas. So, I mean, if you have not seen it once, it's actually very difficult to make a diagnosis. So this is actually, this is chikungunya. This is a child who also had flushed, dusky peripheries, CRT was high, and had these vesicobullous lesions with underlying erythema over the thighs and abdomen. Nikolsky's sign was positive. And importantly, the oral mucosa and conjunctiva were not involved, and the systemic examination was normal. On further history, we found that the mother actually had fever with joint pains about a week ago. The main differentials for skin lesions presenting like this are staphylococcal scalded skin syndrome. But for scalded skin syndrome, often the lesions are often in the face, and it's around the mouth that you actually see those lesions. So whereas with chikungunya, it's not like that. 10 is another possibility, toxic epidermal necrolysis. Now, this again, the lesions are often involving the mucosa as well. Whereas here, mucosal involvement is not there. It is predominantly lower limb involvement, and this kind of one hyperpigmented resolution to this rash is very, very, very much like chikungunya. So diagnosis is by doing chikungunya IgM, and if it's positive, I mean, you have the answer. Sometimes you can even take fluid from the bulla, and you can look for the chikungunya virus, and the PCR may be positive. So that's another way of making this diagnosis. So this is chikungunya fever with vesicobullous manifestation with shock. Having said, I mean, mind you, this happens only in young infants. This kind of a rash does not happen in older children, but it's sort of very pathognomonic of chikungunya. This is the next case. This is a 1-year-old child. I mean, I'm sure many of you must have seen a rash like this. Fever for 3 days and an erythematous rash, which was present over the face and the trunk and the extremities. And importantly, this rash blanches on pressure. Now, I mean, I don't think, I mean, if you've not seen it, this is very, very much like the acute febrile rash of dengue. And the important thing about this rash is that this rash is actually in the initial part of the illness. So it is possible for this child to actually become worse after you recognize this rash. This is the other rash which happens with dengue, which is the islets of white in a sea of red. Now, this does not blanch on little areas of islands where it looks sort of, which are clear. So this is also very, very pathognomonic of dengue. And this is not it's a convalescent rash. So the two types of rash in dengue, one is the febrile rash, which usually occurs in the first 24 to 48 hours, which is a transient generalized maculoerythematous rash that blanches on pressure. And then the next picture, what I showed you, was the convalescent rash of dengue, which starts about 2 to 3 days after the fever effervesces. It does not blanch on pressure. There may even be pruritus, and it can last for up to a week. The good thing about the convalescent rash is, once they've developed this rash, you can actually rest easy because this child is unlikely to become sick because of dengue. So if this rash is there, the convalescent rash is there, it's a good sign. Febrile rash is there, you still have to worry about whether this child is going to become sick or not. So that is, so we've looked at two common illnesses, dengue and chikungunya. Next, I go to another slightly uncommon scenario. So this is a 4-year-old child who was previously healthy, who presented to us with fever for 4 days. She had no localizing symptoms. The face was flushed, extremities were flushed. CRT was normal. She was tachycardic. The BP was normal. There was epigastric tenderness. The liver was about 2 to 3 centimeters. Other systemic examination was normal. So this is a child who actually has like an undifferentiated febrile illness with the epigastric and the tender hepatomegaly. Now, this could very well fit in with dengue with warning sign, which is the hepatomegaly with tenderness. So, and this was the blood count. The hemoglobin was 13.2, which may be slightly hemoconcentrated. Total count actually showed slightly low counts with 62 neutrophils, 31 lymphocytes, no eosinophils. Platelet count was slightly low at 1.1 lakhs. Malarial parasite was negative, and the dengue NS1 as well as IgM was positive. So there's no doubt about the diagnosis here. It is somebody who came with dengue with warning signs. On day 6, she became more flushed, became edematous, became afebrile, became tachypneic. There was much more hemoconcentration, and the platelet counts fell drastically. Now, we managed this child with fluids. You can make out that there is also a veil sign on the chest X-ray, which is basically small pleural effusion taken on a lying down child with an X-ray taken down on a lying down child. Just reflects a small pleural effusion signifying capillary leak. So this child had dengue and child improved. But on day 9, child looked sick again, and there was reappearance of fever with some skin lesions. Now, these skin lesions, I mean, I think you must recognize these skin lesions because, again, these are pathognomonic. Now, these are like sort of these necrotic lesions with these ulcers with undermined edges, and there are many of them. I mean, I've shown you one in a little more detail, but there were many of these lesions for this child. So, I mean, I know I can't ask you questions in reality. So this is Ecthyma gangrenosum. Now, Ecthyma gangrenosum is it's important to make this diagnosis because the most common cause of this disease is actually Pseudomonas aeruginosa. And normally the antibiotics that we use to treat secondary infections, if it does not necessarily cover Pseudomonas. So you need to cover for Pseudomonas. So this is as a result of bacterial invasion of the walls of arteries and veins in the skin and subcutaneous tissue. It could either be due to septicemia or due to direct inoculation into the skin. It usually is red initially, then it becomes edematous, it becomes a pustule, then there is hemorrhage, necrosis, and then there is this ulcer formation with the scab. Now, this whole progression can happen very quickly within 12 hours, and the most common organism is Pseudomonas aeruginosa. So I'll show this slide again. So this is Ecthyma gangrenosum. There are other organisms which can cause this, like Staphylococcus and as well as Streptococcus, but they are uncommon causes of ecthyma. Now, so Ecthyma gangrenosum. This is another case. This is a 6-year-old child with fever for 8 days who had a mild headache and nausea. There was breathing difficulty and decreased urine output. The child was treated elsewhere with amoxicillin and clavulanate. While the child came to us, was slightly tachypnic, was in obvious respiratory distress. There was liver enlargement and spleen enlargement. Now, I am sure, like, at this day and age, after seeing many cases of fever, acute, undifferentiated fever with this kind of a eschar, the diagnosis is easy. So this is scrub typhus. Now, that is a very typical eschar, even though the site may not be very typical. The normal site for eschar is usually in the folds of skins. Now, but this is a eschar. And once you find this, your diagnosis becomes that much clearer, and it's often scrub typhus. The scrub typhus, the eschar itself is actually painless. So patients don't recognize it as something. You have to look for it. And where you look for it is actually to look at skin folds, especially behind the ear, behind the in the nape of the neck, in the axilla, the groin, genitalia. So these are the areas where you have to look. Now, this is a picture of an eschar on the eyelid. You can have it in any part of the body. Sometimes it can even be in the scalp. This is the picture of a scabies, the trombiculate mite, which causes, which transmits scrub typhus. This is invisible to the naked eye. It's only 2 to 4 millimeters in size. So it's like a speck of dust. If you were to see it under a microscope, you can see it. But otherwise, if you were to see it on a naked eye, it's like a speck of dust. So you really can't make out. These are pictures that we took from rodents, from the ears of rodents. In our own series, when we've looked at how many people have eschars, 40% of all our patients diagnosed with scrub typhus had eschars. What I want to emphasize is the site where you want to look. Folds of skins, genitalia, whether it be males or females. So scrub typhus, that was scrub typhus. Now, this is a 2-year-old boy with fever for 7 days and a rash over the past 2 days, had a hepatomegaly, no splenomegaly. Investigations were really unremarkable. Platelet counts were normal. Total counts were also normal. But this child had a very typical kind of a rash. Now, this is a rash which is papular. It involves the whole body, but very importantly, it involves the soles and the palms of the child. Now, you can make out this erythematous papular lesions involving the palms and soles. Now, if you don't recognize this, it's very difficult to make a diagnosis because this is spotted fever rickettsiosis. Now, rickettsial spotted fever, it's difficult to diagnose because not everybody does spotted fever IgM. So if you find fever and a rash, which is generalized, papular, and involves the palms and soles, that is very like spotted fever rickettsiosis. One important differential, if you might consider, is hand, foot, and mouth disease. But for those of you who've seen it, hand, foot, and mouth disease is often the rash is vesicular. It's only in the hands and feet. It might extend up to the elbows and legs, but never on the trunk. And usually you find some vesicles or ulcers on the throat as well. So rashes involving the hands and feet, very likely that this is rickettsial spotted fever rickettsiosis. What the organism is exactly, we are not very clear. It is probably Rickettsia conuriae, and the vector is usually a tick. I just show you some more pictures of spotted fever rickettsiosis. So this is again, you could confuse this with disseminated meningococcemia, but we don't see meningococcemia so much as in some other populations. I think in India, if you find rashes like this, these are more likely to be spotted fever rickettsiosis or strep typhus or even purpura fulminans rather than meningococcemia. So these are some more rashes. Now, whatever rashes that I'm showing are all children with spotted fever rickettsiosis. Now, you can actually culture the organism from a biopsy if you take it from that site. So again, this is all, I mean, you can see the mild edema and the kind of a rash. I mean, the papular rash for involving the palms and soles. So that spotted fever rickettsiosis diagnosis is by doing a spotted fever IgM. Treatment is very simple. You can give doxycycline or azithromycin. If you have resistant strains, then you could use rifampicin. But doxycycline almost always works. Now, I want to just show you a few cases of diphtheria, because I mean, it's important for people to think about diphtheria because it's increasingly becoming prevalent, and it's a disease with very high mortality if you don't really take good care of, administer antitoxin at the appropriate time. So this is a 13-year-old child who came with neck pain and fever, and throat examination shows this membrane, which is involving the tonsil, and very importantly, it is also going towards the uvula as well. So that is a key thing. I mean, if you have a membrane which is not just on the tonsil, and if it is spreading beyond the tonsil, that is more and more like diphtheria. I'll just show you some more pictures. It usually has a dirty gray pseudo membrane. I mean, if you try to peel off, it might bleed. And the biggest differential for this is infectious mononucleosis, which is a self-limiting disease. But if you miss diphtheria, you could land up with very significant complications. So this is another picture of the membrane and a bull neck. So this is somebody with significant neck node enlargement as well. So whenever somebody comes with fever and sore throat, just watch out. There is diphtheria in the mix. So make sure that ask for a history of vaccination, as well as look to see if the membrane is actually going beyond just the tonsil, and look for any bull neck appearance. Because if that is there, you need to administer antitoxin even before you make a confirmatory diagnosis. Now, respiratory diphtheria can be over the nose, larynx. It could be over the tracheobronchial tree, and it can even cause sudden death because of the membrane blocking the trachea. Now, there are systemic manifestations, which is what we want to prevent. I won't read through it. So myocarditis usually happens about 7 to 14 days after, and you can die of it. There is direct renal toxicity, which can again lead to hypotension as well. Neurological toxicity usually happens a few weeks after the primary infection, but there can be palatal palsy even acutely. So these are all severe complications of diphtheria, which if you don't administer antitoxin, you cannot prevent. So I just want to show you a few pictures of cutaneous diphtheria, because these are all becoming, again, more and more common. The good thing about cutaneous diphtheria is, even though they have membranes, the toxigenic effects of diphtheria are not so much as with pharyngeal diphtheria. So this is this is a picture of diphtheria with an ulcer with undermined lesions and a weeping edges. So now this, you might find it in many, many small children who are walking around, playing around. You might even mistake it for impetigo. So, but if you actually swab them, you could find these organisms. This is a child whom we saw. This was umbilical diphtheria. I mean, there was a dirty gray membrane over this thing. This picture was taken a couple of days after we started on antibiotics. But again, the smear showed Corynebacterium. So these are all emerging. So just keep a watch out for this. So you can diagnose by doing a smear or a culture or PCR for diphtheria and toxin. Now, important thing is the diagnosis of diphtheria is based on clinical examination. If you have an upper respiratory tract illness with an adherent membrane of either the nose, pharynx, tonsils, or larynx, you can make a diagnosis of probable diphtheria and start administering antitoxin. Confirmation is by isolation of the organism, or by histopathological examination, or if you have an epidemiological link to a lab confirmed case. Treatment, like I said, again, antitoxin, antibiotics, management of complications, which is airway, cardiac, and neurological, and isolating the child for respiratory disease, and contact prophylaxis for all those who come into contact with that child's respiratory secretion. So important disease. Now, this is a little more rare, but wherever I've actually shown pictures of this, there is somebody who's contacted me later and said, I've seen somebody like this. What do you think it is? So that's why I'm putting up these scenarios. So this is a 20-month-old who presented with swelling, on the left buttock, which over a period of 12 months, it was progressive. Somebody did an IND twice, no pus. Child was unable to walk. There was no bony involvement. There was no fever. There was no injury, no bite, no other infections. This is the same child's picture from the front. The swelling became more indurated. It progressed to involve the scrotum. It became ulcerated. There were no regional lymphadenopathy or palpable organomegaly. The child had grown well. So hemoglobin was slightly low. Total count was high. There were more eosinophils. Platelets was high. X-ray didn't show any bone involvement. Biopsy of the lesion showed infiltrates with eosinophils, lymphocytes, histiocytes, and Langerhans type giant cells. This is another child. Different child, 3-year-old, again, thigh swelling, which progressed to the buttock and scrotum. Again, a well-grown child, non-tender, indurated lesion involving the thigh, buttock, and scrotum. Again, here, the total count was slightly high, more eosinophils, platelets were high, no bone involvement. Biopsy showed granulomatous paniculitis with eosinophilia. So the first child, actually, fungal stains showed broad aseptate hyphae. And the second child showed some fungal elements, not any very clear. But these broad aseptate hyphae, normally you think it's zygomycosis or mucormycosis. But these are healthy children. And mucormycosis, you usually see them in the face, you see them in the orbit, you see them in the CNS, abdomen. But these are in the extremities. The culture group, Basidiobolus ranarum. So this is basidiobolomycosis. If you have not seen it, you will never know it. But if you've seen it once, you can easily recognize it the next time. So zygomycosis, like pathogenic zygomycetes, belong to two orders. One is mucorales, which causes mucormycosis, and the other one is entomomorphthalus, which actually causes entomophthalomycosis, of which there are two things, basidiobolus and conidiobolus. And what I've shown you here is basidiobolomycosis. They are also called subcutaneous zygomycosis. This happens in children who are healthy otherwise. Treatment is very simple. If you give them, it's like homeopathic treatment with potassium iodide, and it works like magic. Within 2 days, the child is better. So this is potassium iodide this is to be treated at this child with potassium iodide and cotrimoxazole for 3 months, monitored for hypothyroidism, renal failure, and hyperkalemia. And the child became better. This is the second child, again, after 2 months of treatment. This was a WhatsApp consult which was sent to me. This is a 6-year-old girl who presented with bad cellulitis of the right calf region, which has been gradually worsening over 6 months, did not respond to multiple antibiotics. Broad spectrum antibiotics were started, debridement done, pus culture group Proteus, and the biopsy showed extensive necrosis with microabscesses and fungal elements which were aseptate. Started on treatment with conventional amphotericin, no improvement. And so this was the query from the doctor. So he said, should I give some other antifungal or should I consider any other differentials? Now, this is the lesion. No, you can see that the whole leg is indurated and there is necrosis around. So here again, and they had already seen broad aseptate fungal hyphae. So this is also subcutaneous zygomycosis, very likely Basidiobolus or basidiobolomycosis. This is a child after treatment with potassium iodide. It really works like magic. So couple of other pictures, and with this I'll stop. So this, I'm sure all of you will recognize what this is. This is scabies. These are papillary lesions which are in the intertriginous regions. This is not a problem to recognize. This is scabies. Now, on the other hand, you might find children coming with nodular lesions on the genitalia. Now, these are not uncommon, and some of these nodular lesions can even become bullous. So you can have bullous scabies or nodular scabies, often found in genitalia, but you can also find it in the axilla, in the groin, and even in the buttocks. So basically, when they scratch, they develop these lesions. This is nodular scabies. Treatment is just like scabies. You give 5% permethrin, it heals very well, and it doesn't recur. It does not mean the patient has got some underlying immunodeficiency. On the other hand, this is another form of scabies, which is also called crusted scabies. Now, this happens in immunosuppressed individuals. This child I actually saw, this is a 3-month-old who presented actually with these lesions and subsequently came from an orphanage, subsequently turned out to be HIV positive. And this is after treatment with permethrin as well as ivermectin. So this is called Norwegian scabies or crusted scabies. Here, it's slightly different because this happens in immunosuppressed. Norwegian scabies, usually when patients with AIDS, leprosy, lymphoma, Down syndrome, or elderly, and it's transmitted by direct contact. So people with normal scabies can give this to other people. Now, the important thing is these are very, very highly infectious because the amount of scabies mites are about 6,000 mites per gram of debris. So they're very highly infectious. So you probably have to treat the whole the household if this is there. Treatment is easy with the topical 5% permethrin and ivermectin, not just permethrin. Yeah, so I think I sort of exhausted my 20 minutes. I hope this has been useful. So summarize, I showed you a few pictures of vesiculobullous lesions of chikungunya, acute febrile rash and convalescent rash of dengue, eschar of scrub typhus, rash involving the palms and soles of spotted fever rickettsiosis, diphtheria of pharynx, skin and umbilicus, basidiobolomycosis, which is a form of subcutaneous zygomycosis involving the buttock and the genitalia and the lower limbs. And finally, I showed you scabies, which was nodular scabies and like normal scabies, nodular scabies, and Norwegian or crusted scabies. Thank you so much for your patient listening. I really wished I was there in Pondicherry celebrating this time with you. Thank you.
Thank you very much.
Thank you, sir, for the excellent presentation. Any questions from the audience?
Any questions from the audience? You can tell your questions over mic.
Potassium, how it is available, sir?
So it's actually available in the chemist's shop. So in our hospital, we actually buy potassium iodide and keep, and we dilute it in such a way that we get it as like it's 30 milligram per kg is what you need to give. So we dilute it in such a way that usually it's about 4 drops TID, something like that. It's like homeopathic treatment that you give. So usually you start potassium iodide very slowly. You start off with 1 drop TID. Our concentration is usually one drop is 100 milligrams. Sorry, 1 drop is 100. I mean, 1